Hello. It's a real pleasure to be presenting at the Primary Immunodeficiency Conference. Michele Manion and I are thrilled to be here to really educate and speak to you about primary ciliary dyskinesia and primary immunodeficiency sorting zebras, two rare diseases that really overlap. My name is Stephanie Davis. I'm the chair of pediatrics, but most importantly, a pediatric pulmonologist who has spent the last 20 years working on rare lung disease, and the last 15 focused on primary ciliary dyskinesia. And recently, we have been also trying to better elucidate or understand the overlap between PCD and PID. I am now going to turn this over to my colleague and friend, Michele Manion, who will start the presentation.
Hello, I just want to reiterate Dr. Davis's comments that we are delighted to be here and very much want to thank the organizers for including us in this important conference. My name is Michele Manion, and I'm the founder and executive director of the Primary Ciliary Dyskinesia Foundation for PCD, and I'm also the parent of an adult with PCD. Can we move to the next slide? So as Dr. Davis mentioned, we've titled this talk Sorting Zebras. And of course, the zebras reference is to the medical adage that young doctors hear when you hear hoofbeats, think horses, not zebras, because it's usually more productive to be looking for common causes for problems and not the rare or exotic causes. However, when you are a zebra or you have a zebra in your life that you love, this can be a very, very frustrating experience. Typically, it requires multiple visits to doctors. Up to 8 different specialty physicians will see a patient with a rare condition. There can be up to 3 misdiagnoses, and it takes an average of 7.6 years to get a diagnosis. So that is the average. And we know that for a lot of families, it's even more challenging than that. Individually, these disorders are rare. They affect less than 200,000 people in the US, but collectively they are not rare. There are 7,000 different rare diseases and they affect 1 in 10 people. So we are looking at a population of about 25 million people with a rare disorder. So it's very important to appreciate the public health issue that this is and how challenging it can be to get the diagnosis and to get it right. Next slide. So these are all unique disorders, but what if 2 of them look alike? What if we are dealing with 2 zebras? How does that impact the ability to get the correct diagnosis? Does it make misdiagnosis even more common? In our experience in the PCD world, it appears that it does, and the overlap happens to be between primary immune deficiencies and primary ciliary dyskinesias. These disorders share similar features, which increases the risk of misdiagnosis. And in some cases, this can have potentially devastating consequences. I would like to just share in my particular case with my daughter, she was initially diagnosed with a primary immune deficiency. We were told that she had deficiency of IgA, which actually corrected itself by age 5, and we had to start the diagnostic process all over again. Next slide. And now Dr. Davis will spend some time telling you about primary ciliary dyskinesia.
So let's spend some time, as Michele said, highlighting what is primary ciliary dyskinesia. Again, PCD is rare. We think the incidence is about 1 in 12 to 20,000. But quite frankly, it's often underrecognized, not diagnosed, as many rare diseases. So the true incidence is currently unknown. The mutations occur in any of several genes. And in fact, right now, about 50 genes have been identified that lead to primary ciliary dyskinesia. And these genes control modal cilia, which are along your airway epithelium, so in your airway, in your ears, within your sinuses, and they impact the way the cilia moves back and forth and the function of the cilia. And you can see here, this is a schematic showing the cilia with what we call the 9+2 figuration here from the cross section of the cilia. And you can see here where we have outer and inner dining arms, as well as the central microtubules and radial spokes. And I won't go into a lot of details about the microtubules and things of that nature, but just to understand that you can have defects in any of these areas, anything along the cilia, and it can lead to primary ciliary dyskinesia. There has really been an explosion in understanding the genes that impact PCD over the last 20 years. And so that has helped with diagnosis for sure, but we still think there are many patients that remain undiagnosed. Here are some of the ultrastructural defects that we see in primary ciliary dyskinesia. So if you remember, here's the 9+2. We have your central apparatus in the middle, and you have the 9 microtubules here on the outside. And you have these things called outer dining arms and inner dining arms. And you can have a lot of different kinds of defects. You can actually have complete absence of those outer dining arms, which then makes the cilia not move the way it needs to. And the reason that's important is the cilia help to move mucus out of your airways. On top of that, you can have both outer and inner dining arms absent. You can also have what I call almost complete collapse, where you have absence of the inner dining arms and what we call microtubular disorganization. Just basically everything is completely disorganized. And finally, you can even have complete absence of the central complex. You can also have absence of the inner dining arm, but I have to say you have to use caution when making that diagnosis, and you really probably need about 3 biopsies to confirm this diagnosis. So the main reason I'm highlighting this is because it's difficult to make the diagnosis. It is hard to read these what we call electron microscopy pictures for both pathologists and those, and you really need experts to read these. And sometimes you can even miss the diagnosis because it's only on certain cross sections of the cilia. So this has been quite a challenge over the last several decades, which is why genetics has definitely helped from a diagnostic perspective. As I said, there are at least 50 genes that cause PCD. You can see the first gene was identified in 1999. We have continued to have several other genes identified over the last 20 to 21 years. So I thought it might be nice for people to see, what does normal cilia function look like? And here you can see it. Here's what your cilia look like. They move very rapidly in a backward-forward motion, and that helps to move the mucus out of the airway. So these cilia are sitting on the epithelial surface of the airway, so that mucus, that's kind of a mucus layer that sits above that cilia, is easily taken out of the airway. It's almost like an escalator moving the mucus out, so that you basically can get the mucus out and either cough it out or you swallow it. And this is in normal people who have normal cilia function. What does it look like if you have primary ciliary dyskinesia? And I think it's pretty obvious the difference. The cilia are not moving in any kind of coordinated fashion. The mucus is not effectively being moved out of the airway. And because of this, you end up with mucus sitting in your airway. You develop airway obstruction. You get infections in your airway, and you can end up with pneumonias and bronchitis, as well as the same phenomena occurs in your sinuses, and you can end up with sinus infections and ear infections. So again, I think it's very remarkable to see the difference between the first video I showed you, where the cilia was moving coordinated, and here clearly the cilia aren't moving coordinated at all. So now let's talk a little bit about primary immunodeficiencies, which you also are well aware are rare, but collectively are more common than PCD, occurring at about 1 in 1,200 live births. It is also, as you know, primary immunodeficiencies are genetically complex. They have right now about 430 or more genetic mutations across 403 distinct genes, as well as some acquired forms have been identified. And some primary and many primary immunodeficiencies have been well characterized compared to PCD, with 130 different disorders grouped into 9 categories. But the main thing we wanted to highlight as Michele and I, are how primary ciliary dyskinesia overlaps with some of the manifestations you see in primary immunodeficiencies. So now Michele is going to talk about how we do see overlapping features and similarities with these 2 disorders.
Thank you. And I just want to point out that in our group, in the PCD Foundation advocacy group, we have frequently run across cases where people have been told they have PCD when in fact they actually have a primary immune deficiency. And so we're just going to talk a little bit about how that could happen, looking at the similarities and differences in these disorders. So in the early years with PCD, there's lower airway disease and rhinosinusitis, so upper and lower airway disease, and also middle ear disease. In some primary immune deficiencies that have respiratory involvement, you have a very similar phenotype with lower airway disease, rhinosinusitis, and ear infections. And in both cases, these infections are often dismissed as daycareitis or just kind of routine infections of childhood. And the fact that there may be something more going on can be overlooked in the primary care setting. Next slide. As these individuals start to grow up, there are still similarities. The bug profile can be worse. They get worse bacteria that is more difficult to treat. And as a result of that, structural damage to the lungs or bronchiectasis can occur. And it's very common in people with PCD. It actually can occur in childhood, and it may occur in people with PID as well. The upper airway and ear disease continues to be difficult to manage, and that is also the same for primary immune deficiency. Next slide. But there are some key differences that are very important. So with PCD, the symptoms that we've described usually start at birth or shortly thereafter in the very early months of life. And neonatal respiratory distress is very common. About 80% of children with PCD will end up in NICU requiring some ventilatory support or breathing support in the neonatal period. And PCD is also associated with something called laterality defects. And this is because there are cilia, a specific kind of cilia in the embryonic period that must function well for organ placement to be sited correctly. And what happens is, in the absence of the signals from those cilia, sometimes organs can be completely reversed in a mirror image arrangement called situs inversus. Sometimes they get stuck a little bit halfway, what we call situs ambiguous or heterotaxy. And when that occurs, there's a much higher incidence of congenital heart defects. Additionally, for reasons yet unknown, there appears to be an increased risk of pectus deformities and scoliosis, so some connective tissue issues that we see in PCD. When you compare that to PID, the respiratory symptoms may start later in life. Neonatal respiratory distress is not a common feature in all patients. Laterality and situs defects are also not common, and there's no known increased incidence of cardiac defects or of pectus deformities and scoliosis. Next slide. In the later years, there are also differences that can be identified. In PCD, cilia are also involved in fertility issues. So cilia, for males, the sperm tail shares genes with cilia, and there can be sperm immotility and related infertility. And subfertility for women, because there are cilia in the fallopian tube, and impairment of those cilia may make it more difficult to conceive. There are chronic infections, but they're limited to the upper and lower airways primarily. And there's no increased risk of malignancy in PCD. Contrasting that with primary immune deficiency, there's no known elevated risk of infertility or subfertility for people with primary immune deficiencies. Infections are not limited only to the respiratory system, and there is an increased risk of malignancies in some cases. So now that we've looked at the similarities and differences between these two disorders, let's talk about accurate diagnosis, why it can be challenging, and why it's very important. In PCD, there currently are no approved treatments. So the focus of therapy is symptom-based, and we are trying to prevent bronchiectasis, the irreversible lung damage. Infused therapies used in PCD are largely ineffective, and they can be potentially dangerous. In contrast, PID, some of them do have effective therapies available, and these therapies are targeted at the underlying defect, not at just symptoms. And infused therapies that target the cause of primary immunodeficiency are obviously much more effective in people with these underlying conditions. But most importantly, this is the age of molecular medicine, meaning that therapies are being developed that will target specific genetic defects. And this means that it's critical to have the right diagnosis and understand the right genetic hand that you've been dealt. And this is how we will get accurate therapies for individuals with these conditions, and they can fully benefit from them.
So now I'm going to talk about how to make the diagnosis of primary ciliary dyskinesia, how you can get tested, and just to reiterate what Michele just stated is that an accurate diagnosis is so important, especially in this age where we are having an explosion of medications targeted to specific genetic defects. So in primary ciliary dyskinesia, it is critical that you define the phenotype, that you define the clinical features that are classic for primary ciliary dyskinesia, which I'm going to review in just a second. On top of that, we can do nasal nitric oxide testing, which I'm also going to talk a bit about, which can help lead to the diagnosis of primary ciliary dyskinesia. It doesn't make the diagnosis of PCD, but it can certainly help to guide the clinician with the diagnosis. We also, the other areas that we look at in making the diagnosis are ultrastructure, which I talked about earlier in the presentation, where you basically do a cilia biopsy and you look at the structure of the cilia. That can help in making the diagnosis. The cilia beat, some places look at just the beat of the cilia to make the diagnosis. Antibody stains are another thing that have been used in specific labs around the world. And genetic testing, from my perspective and from Michele's perspective, is really the route that I think we're going to help with ultimate diagnosis of PCD. Now, in primary immunodeficiencies, there is a pattern of recurrent infections and other abnormalities, as many of you know very well. A number of lab evaluations occur in making the diagnosis of primary immunodeficiencies, which are listed here on the slide. In fact, just to reiterate, many of our patients with the ultimate diagnosis who ultimately get diagnosed with primary ciliary dyskinesia undergo these lab evaluations before they actually get diagnosed with PCD. And genetic testing is certainly a way to make diagnosis for many of the patients with certain primary immunodeficiencies. But I'm going to focus a little bit on PCD and what are the classic clinical features. You really need to have these to make the diagnosis. Patients with primary ciliary dyskinesia have chronic airway disease. All adults eventually have bronchiectasis or irreversible structural lung disease. They have chronic rhinosinusitis, nose chronically running, recurrent sinus infections, or may end up with multiple sinus surgeries or ear tubes. Patients with primary ciliary dyskinesia have chronic middle ear disease that's worse in early childhood, where you may get multiple ear tubes. And the other thing, as Michele mentioned, is that approximately 85% of patients with primary ciliary dyskinesia have neonatal respiratory distress despite being term. They're born on time, they end up on oxygen, and they can sit in the NICU for a long time or be sent home for many days on oxygen. Sinus inversus totalis is seen in about 50% of patients. And we also know that there can be other laterality defects referred to as heterotaxy in at least 12% of our patients. Male infertility is definitely a problem because of the defective sperm motility. Scoliosis, as was mentioned earlier, as well as airway disease leading to problems with lung function or spirometry, and pectus excavatum can also be seen. What we know is that these patients have chronic wet cough every day, from really the first 6 months of life. They are born, most of them, with neonatal respiratory distress despite being term, and they have chronic nasal congestion also beginning during the first 6 months of life, as well as at least 50% can have the situs inversus. So those are the classic features that really help us in defining if a patient has PCD. So once you sort that out and you ask those questions, and again, it's a cough every day, it does not completely resolve with antibiotics, and it does not go away in the summer. You want to then head down the road to make the diagnosis. I mentioned nasal nitric oxide measurements, and here this is where we basically measure the nitric oxide levels in your nose, and you can see here it being conducted in the lab at UNC. And mainly I wanted to highlight that nasal nitric oxide measures are dirt low in primary ciliary dyskinesia. And you can see here patients with PCD in red, and then these are just healthy controls, and you certainly see that it's very low. But a word of caution, we are learning as we define the phenotype, over the last several years, that some patients can have a little bit more mild phenotype, and their nitric oxide levels, in fact, are a little bit higher than this cutoff you see here at 77. So in other words, it can be almost in the more normal range. So we're really understanding this and really getting a better understanding of this disease over the last 20 years. But certainly if a patient has low nitric oxide levels at their baseline, this is a sign that, hey, I need to do further testing. Let's either do a cilia biopsy or perhaps send them for genetic testing, or if you're in a really specialized lab, looking at cilia bead or antibody levels. So the Genetic Disorders of Mucoussolute Clearance Consortium, I serve as the principal investigator for this consortium along with Tom Ferkel. Previously, it had been Mike Knowles and Margaret Lee, who had led it for 15 years, has really been established to systematically characterize and distinguish clinical features. And we, in this last cycle, have decided to focus on distinguishing and characterizing clinical features to help us with the diagnosis of not only PCD, but also primary immunodeficiencies. We know that pulmonologists and other physicians often see these patients. They have overlapping phenotypic features, and we want to try to understand those differences so patients can be correctly diagnosed. Both the Immunodeficiency Foundation and the PCD Foundation are our participating patient advocacy groups, and we work very closely with them on this initiative. If you're interested in participating in any study, I've put contact information here on the slide. We have 3 main projects that are occurring. Our first project is understanding genetics of lung disease in children and adults with both primary ciliary dyskinesia and primary immunodeficiency. The second project is really focused on PCD and trying to define lung exacerbations and treatment responses in primary ciliary dyskinesia. And our third project is another overlapping project where we're trying to understand sinus disease, ear infections, the upper airway manifestations in patients with primary ciliary dyskinesia and primary immunodeficiencies. I list here our consortium. You can see that we're really spread across North America. We have a Toronto site and a Montreal site. Sharon Dell was the lead in Toronto. Felix Rachin is there now helping as well. But this is really where our sites are located, so that we have this on purpose across North America so people can participate in these different research opportunities. So let's circle back to the difficulty in distinguishing zebras. And I want to talk about a case of a patient who presented to us at 11 years of age, again with chronic nasal congestion, classic clinical feature in PCD, a wet cough, 3 previous pneumonias, very low lung function, and just a lot of sinus infection. This child did not have cystic fibrosis. The cilia ultrastructure was normal, but she did have a very low level of nasal nitric oxide. This was confirmed to be low a year later. So the thought was, well, she probably has primary ciliary dyskinesia. This child did not return for follow-up for 2 years. Her lung function went back to normal, but she had bronchiectasis, or irreversible structural disease, and a lot of lung lobes. She also grew this infection called atypical mycobacterium, which you typically see in patients who have PCD or cystic fibrosis or primary immunodeficiency, and this is treated at a different hospital. Then she came back and had another nasal nitric oxide level, and it actually returned into the normal range. So she had two very low ones, and then the nasal nitric oxide came to the normal range. We did not see her here for several years. The family reported she was doing well for 6 years. She was very active. And of note, this child was out of state. So she was being followed somewhere else for her clinical manifestations or for her clinical issues. We had mainly seen her as a second opinion as part of her research protocol. She then developed a sudden acute illness, was diagnosed with hemophagocytic lymphohistiocytosis, and was identified as having GATA2 deficiency. So where we had thought she probably has PCD, did not give her that diagnosis, but thought that it was a likelihood. She actually, in fact, had GATA2 deficiency. So here you see significant overlap between PCD and PID. So I'm now going to turn this over to Michele to conclude.
So I think what we hope that you got from this presentation is that there are many overlapping symptoms between these two disorders, and that accurate diagnosis is important. And to get it, you probably will have to go to a center of excellence. These are difficult diagnoses to make. Dr. Davis shared a case study with you, and I think it's also important to point out that this patient almost certainly had a basic PID workup before she even came for PCD workup. So it really needs to be a very in-depth workup for primary immune deficiency and not just the standard things that you get. So a center of excellence for PCD and or PID is really critical in making the distinction between these disorders. We need further research to identify genes to get a full, complete picture of the genes in both of these disorders. We need to describe the symptom variability, look at how the genes affect how symptoms are presented. And then, of course, the goal is to develop personalized therapies. We really are at the tip of the iceberg in understanding these rare disorders. Next slide. And we just want to acknowledge the hard work of everybody in this consortium. We very much appreciate working with the folks from the IDF Foundation. It's been just a wonderful working relationship. The GMCC Consortium, these are all the physicians involved. UNC is of course, the lead group for this whole PCD research effort, and we very much appreciate that. And thank you very much for your time as well.
Thank you. And we are happy to take questions. Thank you very much.
Why, hello, everyone. This is Christopher Scout-Schuns, Vice President of Research at the Immunodeficiency Foundation. Hope everyone has enjoyed the conference to this point. I know I have, and thoroughly enjoyed this last presentation. Before we get to the question and answer portion of this, please remember that each individual's treatment and condition is unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified health provider with questions concerning a medical condition. At this time, please join me in thanking Dr. Stephanie Davis from the University of North Carolina at Chapel Hill and Ms. Michele Manion from the Primary Ciliary Dyskinesia Foundation for that wonderful presentation, and saying welcome to the Q&A portion of this session. All right, thank you both. Do you want to just say hi real quick to our audience live here?
Hello, everybody. It's great to be here. It's a real honor to be here with Michele.
Ditto. Thanks so much to the organizers for allowing us this opportunity to talk about two conditions that are close to our hearts.
Great. So let's get started. So I see we've got one question here already in the chat. So folks, I'm going to continue to entertain questions as long as we have them. So if you've got them, please put them up, because if you don't and I don't see it, we might end this session prematurely, and I don't want that to happen. All right, so here we go. Here's the question. The slide with a list of genetic defects went pretty quickly. I was told I have a DNA H1 defect and that it is an unknown form of ciliopathy. I also have CVID. Can they occur together? If not, are there other tests I should look into?
I can start, Michele, and if that's okay. Yeah, so that's a great question. So there are case reports in the literature of patients with primary ciliary dyskinesia, so DNH1 defects, also having either immunodeficiencies or CVID. But this is very rare to have them together, though it has been reported. I would just say it would be very important for you to make sure that you are seeing a physician who has expertise in primary ciliary dyskinesia. There are several centers of excellence, which Michele can go into around the country and throughout North America, because interpreting these genetic tests in primary ciliary dyskinesia is very challenging. And sometimes the genetic test can potentially have physicians think that perhaps this patient does have a PCD, but in fact the variant may in fact not be disease causing. So the first thing I would say is you want to make sure you're going to a PCD center of excellence, and to be sure that in fact you do have a ciliopathy. Seeing an expert with PCD, and it is possible, though rare, that you could have both. Michele, do you want to say a little bit more about that?
No, just kind of reinforcing the same thing. One of the biggest issues we have is interpretation of genetic tests, because it is a primarily recessive trait, so you have to have two pathogenic mutations on the same gene, and often that is not what it comes out in a genetics report. So it's very important to have somebody look at this testing who actually understands PCD genetics.
Excellent. So actually along those lines, could you, either one of you or both of you, please expand on where we are currently with genetic diagnoses in PCD and what perhaps some of the clinical symptoms might be associated with these genetic diagnoses?
Absolutely, I can start with that. So there's really been an explosion of genetic, of understanding genetics in PCD over the last 2 decades. Right now, at least 50, if not a little more, genes have been identified associated with primary ciliary dyskinesia. It seems like every month there's a new gene identified. We certainly know that certain genes, like CCDC 39 and 40, are associated with more severe clinical symptoms. And there are certain genes, like RSPH1, that's associated with more mild symptoms. So we're really, over time, are getting a better understanding of these genotype, phenotype, or genetic and clinical symptoms associations. And this is something that we are continuing to explore. But I do think we've made significant progress in genetic diagnosis. And on top of that, it has really been helpful for many of our pulmonary physicians, ENT physicians, patients, and families to have the availability of genetic testing to make the diagnosis. Michele, do you want to say a little more about that?
Yeah, the only thing that I would like to just make sure people understand is we don't even know all the genes involved in PCD yet. So we know a little, 50 about. We know there are many more. So genetic testing on its own is not sufficient, which is another reason why it's a good thing to go to an expert, because there are other testing things that can be done that can help to confirm the diagnosis. So getting a negative genetic test does not mean you don't have PCD. It just means you don't have PCD from any of the genes on that specific panel, genetic panel.
Yeah. Thanks, Michele. That's really important. And about 60 to 70% of our patients are diagnosed through genes. We also can diagnose through electron microscopy also. Yeah, it's really important to keep in mind what Michele said. Just because you don't hit it on the panel doesn't mean you don't have primary ciliary dyskinesia.
Excellent point. So, you mentioned, both of you mentioned that it's relatively rare to have any type of overlap between PCD and primary immunodeficiency disease. But if there are folks out there, who have a child who may be diagnosed with a primary immunodeficiency disease, what specific symptoms in them might trigger a parent to want to get them to have a workup for PCD?
Michele, do you want to start?
Yeah, I think, first of all, I want to say in our group, in the PCD community, there's a lot more awareness of primary immune deficiency probably than the other way, because almost every person with PCD has also been tested for primary immune deficiency in their diagnostic journey. And we have a lot of people in our group who believe they have both, because that's how it's kind of been explained to them. But the number of people who actually do have both is very rare, and it usually is more of an issue of misdiagnosis. I guess if I were talking to parents who had a question about what things, symptoms they should trigger them looking for PCD, absolutely, definitely any sort of situs thing where the organs are in the wrong place, and along with that, any sort of congenital heart defect. And then symptoms that start almost immediately would be a little bit more indicative of PCD than of typical PID.
Yeah, and just to dovetail into what Michele said, patients with PCD will typically, though I will say we're understanding more about this disease, and it does have heterogeneity in the presentation, will typically have a wet cough every day. Typically that will begin before 6 months of age. Chronic nasal congestion, sinus disease and infection. And 80 to 85% have this respiratory distress at birth, even if they're born on time. So those are some of the things you can kind of dig into. Certainly ear infections are associated with primary ciliary dyskinesia, but that's associated with a lot of childhood diseases, which makes it a little bit harder to use that as a differentiating symptom. But those are the kinds of things that you would think about. With the cough, it may be that the child is treated, our adult is treated with antibiotics, and the cough doesn't go away. It may improve, but it doesn't completely resolve. I mean, this cough is occurring year round. It's not seasonal. So those are the types of symptoms we classically look for in primary ciliary dyskinesia. So if you were trying to understand if in fact those are could I have PCD? Those would be the things I would definitely be asking about. And again, just emphasizing going to a center of excellence with an expert who can help to differentiate that.
And I just want to mention it's not at all unusual for someone with PCD to first be diagnosed with an immune deficiency. My own daughter was on our way to diagnosis. She was diagnosed with an immunoglobulin deficiency, which corrected itself by the time she was 5. But this is not at all an unusual pattern that we see in people diagnosed with PCD.
Very interesting. So I'm going to ask a question that is not, well, it's slightly off topic, but I think it's an important one. So I actually think the collaborative work between your two organizations, it really illustrates where we're going in research and in collaboration. So by that I mean, whether it's the GDMCC or whether it's specifically at any of your centers for excellence, but I think the relationship that I've seen between the PCD Foundation and the other researchers is really to be exemplified by others. IDF does many similar things, but I'd like to hear the both of you briefly talk about the synergies you're able to develop by working together, perhaps, that you couldn't achieve if you were trying things all on your own.
I can start and I'll have Michele chime in. I would say essentially it's like a marriage. We work really closely together and absolutely could not do what we do without the other. I've been working with the PCD Foundation in my role as a physician as well as a scientist for the last 15 plus years. And I think together we have been able to do more for the patients and really improve our understanding of the disease. And I think the reason is because we include each other at the table for whatever the discussion is. And that's both at the PCD Foundation as well as through the GDMCC, which is the Genetic Disorders and Mucoussolute Clearance Consortium. It's our research consortium. Michele and others that are leaders in that organization participate in our regular conference calls. We have conferences together. We work together through the American Thoracic Society. It's really been a great relationship. And I can personally say that many of the leaders within the foundation have been affected through family members, and their perspective is the most important perspective. Having the voice of the patient, the parent, the spouse is the most important voice, and that voice helps us as physicians and researchers know where we need to go and what questions to ask.
Yeah, I agree. When we first started the PCD Foundation 20 years ago, we knew almost nothing about PCD. We had one gene that had been discovered, and what's happened in the past 2 decades to move this forward is nothing short of phenomenal. So it's been extremely helpful, and I'm really excited that we've moved now into the GDMCC into looking at the similarities and differences with related or similar disorders, because I think it's really important that we get this right now and make sure that people have the right diagnosis. We've been concerned for some time that there are people who are being told they have PCD who actually have an immune deficiency, and they're missing out on treatments that could be very important. So this synergy is especially impressive and helpful for all of us, I think.
Great, thank you. And it looks like we have one last question here, and I think you touched on this a little bit, but I'd like to ask it anyhow. So the question is, how often, if ever, is this diagnosed in adults?
It is often diagnosed in adults, so it occurs quite often. I can actually give my own personal story about that. I had an adult in my neighborhood who had basically was not diagnosed until she was 28 years old, had been sweat tested, had workup for immune deficiency, and was finally diagnosed at the age of 28. We see this all the time, all ages of adults that are diagnosed. Many adults with what we refer to as idiopathic bronchiectasis may have primary ciliary dyskinesia. Michele can speak to this even more because she talks to a lot of adults with PCD, but this is something that occurs quite commonly, which is why it's so important that the PCD Foundation and the Immunodeficiency Foundation work closely together, because there is so much overlap, so we can really help patients get the correct diagnosis. Michele, do you want to say more about that?
Yeah, I think that's one of the most frustrating things for us. I mean, there's a pretty clear symptom pattern, but still this is missed. And we even have had people in our group who were diagnosed in the 4th decade of life when they have situs inversus totalis and bronchiectasis, 2 very clear markers that somebody should have thought of PCD a long, long time ago. And it's the problem with being diagnosed as an adult is that a lot of the lung damage has already occurred and is now no longer reversible. So we really want to find people before that happens if possible. But yeah, it's sadly very common for diagnosis to not happen till adulthood.
Yeah, and that's something both of our communities face and know all too well. That journey to get there, unfortunately for many, is a long one. And like you said, it's once the permanent impairment set in, there's really no going back and fixing those. So I think the fact that I think both of you today have done an amazing job pointing out the potential of PCD hiding within primary deficiencies diseases is incredibly important. So thank you for that. So on that note, we don't have any other questions left in the queue, and we're just about coming up on our time anyhow. So our time has come to an end. Thank you so very much, Dr. Davis and Ms. Manion. It's been it's been an honor to have you with us today. Everyone else, enjoy the rest of the conference. We just have a few sessions left. Hope to see you in the next session and then at the closing ceremony. Thank you very much, everyone. Enjoy the rest of the afternoon.
Thank you. Thank you.